Hello, this is Victor Mark, presenting on behalf of our research group at the University of Alabama at Birmingham. I will be presenting our research on the structural brain changes in persons with progressive multiple sclerosis after undergoing a form of physical rehabilitation. We have no conflicts of interest to report. This research was funded by both the National Institutes of Health and the National Multiple Sclerosis Society. I summarize our pertinent findings. Structural brain changes followed efficacious physical rehabilitation for persons disabled by progressive multiple sclerosis. The changes occurred in the direction of healthier structure. The specific form of physical rehabilitation was a kind of behavioral change therapy. The brain structures that we found to have changed involved both white matter changes and also cortical gray matter changes on the basis of a randomized controlled trial. The changes appeared only in the patient group that had undergone behavioral change therapy, and not the group that underwent a control intervention. This is the first report of structural brain changes to have followed a form of behavioral change therapy for multiple sclerosis. Behavioral change therapy, or BCT, is a general term used to describe training that changes self-initiated activity in the community to overcome a particular kind of behavior. This treatment is therefore intended to change behavior and uses behavioral techniques. The commonly used techniques for BCT can include behavioral contracting, that is, involving a contract of activities to be conducted and signed by the participant and also by the trainer. This is a written agreement to conduct the planned activities. Goal setting, based on the individual's desired changes in behavior. Feedback, provided regularly by the trainer. Self-monitoring during the course of treatment. Counseling, to motivate the participant to continue the treatment and change one's behaviors. Problem-solving discussions between the participant and the trainer to overcome perceived barriers to pursuing the prescribed activities. Unsupervised activities that are to be performed outside of the trainer's oversight. Behavioral change therapies, or BCTs, have been developed over at least the past 40 years. Examples include quitting smoking, safe sex procedures, and controlling weight. In regard to physical rehabilitation for multiple sclerosis, there have been clinical trials in this area for the past 40 years. For the most part, these have aimed to improve motor capacity of the arms or legs under laboratory conditions, rather than to improve spontaneous, unsupervised activity outside of the laboratory in the community. There have been more than 200 clinical trials aiming to improve motor capacity over the past 40 years. Most of the time, these trials have succeeded with improving movement capability immediately after the end of the trial. However, the gains of movement ability typically receded within a few months. In contrast, behavioral change therapy to change physical activity for multiple sclerosis has been less evaluated. There have been roughly a dozen such trials over the past decade. The most often used methods were internet coaching or group training. Typically, the lengths of BCT were 3 months or more. However, the retention of gains of activity in the community were not always measured after the end of treatment, or the changes were small. At the University of Alabama at Birmingham, or UAB, our research group has evaluated a specific form of behavioral change therapy called constraint-induced movement therapy, or CI therapy. This form of treatment originated from the basic neuroscience research in laboratory monkeys, extending back to the 1960s into the 1980s, led by Professor Edward Taub, who oversees our research lab at UAB. Behavioral, rather than exercise-based training, was used to change spontaneous self-care by the monkeys after an experimental lesion to the central nervous system that cut the dorsal spinal nerves to one arm, leading to permanent loss of sensation. The monkeys immediately stopped using the arm, even though they still had the capability to move the arm, since the ventral nerve roots were left in place. The experimental treatment involved behavioral shaping, which was using food rewards to condition the animals to improve their reaching with the affected arm, and inhibition of compensating movements by the unaffected arm. This was done by the animal wearing a straitjacket on the good arm. This forced the animal to use the anesthetized arm to perform all self-care skills. Of note, no motor exercise was involved, but rather behavioral changing methods. After only 3 days of this form of treatment, the animals regained completely normal and full use by the anesthetized arm permanently. After the monkey research, Dr. Taub relocated from Maryland to UAB in the 1980s to begin clinical trials to extend the behavioral training methods to persons with chronic neurological paralyzing disease. Dr. Taub and his colleagues at UAB developed CI therapy. There are 4 main methods involved. 1. Extensive motor training on functionally important activities with the more affected part of the body for a couple of weeks. 2. Shaping on the tasks. Participants were urged to complete tasks at their personal best. For example, moving as fast as possible, or as far as possible, or in as narrow as a space as possible, with praise from the trainer on every attempt. 3. Physical restraint of the better functioning arm during the training period through using a padded mitt to prevent dexterous activities, but which still allowed bracing the person as needed for steadying posture. 4. Finally, a group of BCT techniques that are commonly used in other forms of BCT. These include behavior contracting, after-hours homework activities prescribed by the trainer, keeping a daily diary of activities, daily 30-minute problem-solving discussion with the trainer to overcome perceived barriers to performing daily activities. This is called the transfer package. Of note, the content of the treatment is individually designed based on the goals of the participant. Therefore, the participant has a personal stake in the outcomes of the treatment. Here's a demonstration of CI therapy for the upper extremity in a person with multiple sclerosis.
Ready, set, go. Better. 11.50.
Wow.
Ready, set, go. 5-0.
Wow.
The primary measure of treatment is the average score on the motor activity log, or the MAL. The MAL was validated against real-world spontaneous activity by the more affected arm through using wrist-worn accelerometers. The MAL involves rating the quality of activity on each of 30 everyday manual activities with the more affected arm or hand, such as opening a drawer or putting on socks. Each item is scored from 0 to 5. Our group conducted a randomized clinical trial of CI therapy compared to dose-matched treatment based on a program of complementary and alternative medicine methods, or CAM. This involved swimming pool exercise, yoga, meditation, and massage. There were 10 participants in each group. The groups were identical for the MAL score prior to treatment, as well as they were identical for the expectation to improve from the assigned treatment, regardless of the group to which they were assigned. We also had the participants undergo brain MRI scanning at 3 Tesla before and at the end of the 2 weeks of treatment. This was structural brain MRI, not functional fMRI. Here are the clinical results. At the end of treatment, the CI therapy group involved on the MAL significantly more than in the complementary treatment group. At 1-year follow-up, the findings were basically the same. This thus indicated that on the MAL, the CI therapy group retained its immediate gains at 1 year later. Here are the brain MRI changes. This is structural MRI. Diffusion tensor results we already published 2 years ago. These showed that only the CI therapy patients had significant changes in white matter in focal areas. The changes indicated increased fractional anisotropy, or the net linear diffusion of water molecules, which is consistent with healthier axons. In general, in multiple sclerosis, diffusion is often less linear. The new results indicate that on Voxel-Based Morphometry, again, only the CI therapy patients showed changes. The results suggest increased gray matter, which was concentrated in the primary motor cortex. After adjusting for repeated measures, the results were not statistically significant, but occurred in the direction of improved gray matter density. Again, this is only in the CI therapy patients who showed these kinds of changes, or any changes. We conclude that CI therapy is a form of behavioral change therapy by definition. CI therapy resulted in greater use of the more affected arm in persons with progressive MS compared to complementary medicine techniques. The gains in limb use in both groups remained after 1 year, but were much more greater in the patients who had undergone CI therapy. Only the CI therapy patients showed significant white matter cerebral structural changes. Non-significant cortical gray matter increases also occurred only in the group that had undergone CI therapy. Physical behavioral change therapy can improve spontaneous paretic limb use in progressive MS for at least 1 year and in white and gray cerebral structure. These findings align with our prior published results of gray matter changes in persons who had CI therapy for either stroke or cerebral palsy. Further studies are needed to ascertain the consistency of the findings in progressive MS after CI therapy. We suggest that adapting CI therapy for the lower extremities can benefit mobility and leg use in the community. As we have shown already in a published case series for progressive MS, also in our prior published research for stroke. In multiple sclerosis, the gains lasted at least for a year. Thank you.